Good morning, I'm Dr. Giacalone. I work as a vascular and lymphatic surgeon in the hospital Sint-Dimna in Hill and in the hospital Heiligart Ziekenhuis in Mol in Belgium. I have a specialization in general surgery, vascular surgery, microsurgery. I perform the lymphovenous shunts. I had a training from Professor Campisi in Genova, and I obtained a PhD doctorate through the University of Pavia under supervision of Professor Campisi. I obtained my medical degree at the University of Rome, Università Cattolica del Sacro Cuore, Catholic University. I am now working in these two hospitals and performing lymphovenous anastomosis to treat lymphedema patients. Lymphedema is a severe chronic disease. There are approximately 40 million patients worldwide with lymphedema. At this moment, we cannot cure lymphedema, but we can reduce it and stabilize. It's a system that will drain all the water and proteins and lymphocytes from the peripheric tissue. And it's, for this reason, very important. When you have an obstruction of the lymphatic system, you will have an accumulation of fluids and proteins and a higher incidence of infections. There is a primary lymphedema, so it's congenital, and we think that most of these patients have a genetical problem. And there is a secondary lymphedema. Those are mostly patients after cancer. For example, patients who received irradiation, patients where the lymph nodes were removed because of cancer. Primary lymphedema is always more difficult to treat, and secondary lymphedema gives better results. Although when we combine both techniques, conservative and surgical technique, we both have a reduction of the volume of the limbs and better movement, a reduction of the rate of infection. A patient with lymphedema can develop, after 20 or 30 years, a lymphangiosarcoma that is a very aggressive sort of tumor. So I think it's very important to reduce and stabilize lymphedema. The lymphedema can influence a patient from the psychological point of view. And second, it's not only the patient that has a problem, but also the family. You see, some patients end up in a wheelchair, so of course it's not only a problem of the patient, but also of the family that has to take care of the patient. The patient with lymphedema will have a higher chance to develop infections. The range of movement is reduced. Sometimes they end up in a wheelchair, and there is a small risk after 20-30 years of lymphedema to develop a very aggressive tumor, the lymphangiosarcoma. In the last 5 years, we treated approximately 800 patients with lymphedema. A part of it only with conservative treatment, and a part with combined conservative and surgical treatment. Well, we first have to make a stadiation of the lymphedema, and then we have to evaluate if the patient received a correct conservative treatment. In that case, if we still have a swollen limb, then we start thinking about surgical treatment. The result of surgical treatments are better if started very soon. I think it's very important to start treatment immediately, and also to try to reduce and to keep stabilized the lymphedema. First of all, we have to make a diagnosis, stadiation of the disease, to make sure that the patient received up until this moment a correct treatment. Afterwards, we will ask for imaging to have an idea of the extension of lymphedema, and then we can plan a treatment. The planning includes a conservative treatment and afterward a surgical treatment, very often, not always. First of all, to go to a lymphedema centrum, we will do a clinical examination and make the stadiation of the disease. We will observe the progression eventually. We will do some examination like lymphoscintigraphy to have an idea of the disease. And afterwards we can make a planning for the future, conservative treatment and eventually surgical treatment. Well, the lymphoscintigraphy is an examination where you can see the extension of lymphedema. You can see in which way the lymphatic fluid is flowing away from the limbs, from the site of injection. We use that information very often to plan the treatment. Conservative is always the base of the pyramid, and then eventually we can perform surgery. Sometimes, in order to evaluate the location of the lymphatics that are still working, we use fluorescence techniques. We perform very often the MRI of the limbs. We perform a volumetry, so we calculate the volume. What is very important is the compliance of the patient to the treatment. So after conservative treatment and surgery, the patient will always to wear a compressive garment, a stocking. That's very important. And to do some physical exercise and to do manual lymph drainage. Mm-hmm. At this moment is for all the life of the patient. We just started with the research. Everybody has his own field. We just published 2 papers about lymphedema treatment from the conservative point of view and from the surgical point of view. We have good results. At this moment we cannot cure it. We are busy with other examinations, and we are busy with several studies with other universities, for example with the Department of Genetics of the University of Louvain-la-Neuve. After lymphovenous anastomosis, we have almost always a reduction of the volume, a reduction of the rate of infection. The patient can move the lymph much better. Some patients that came on a wheelchair, they could walk again. And I think also for the future, when you have a reduction of the infections, and mostly the infections do not recidivate, you have a very good prognosis. So what I mean, after microsurgical technique, you have immediately a reduction of the volume. The patient can move the lymph much better, and that gives a reduction of the incidence of infections and also the risk of developing lymphangiosarcoma. We have very low rate of complications, less than 1%. Mostly they are infections and eventually deep venous thrombosis and allergy, but the rate of complication is the same as for other operations. I think it's very important to have a hospital that is really well equipped for lymphedema. That's why we call it a lymphocentrum. Why? Because everybody knows in his field enough of lymphedema. Very important to have a complete team. That's why I always say lymphocentrum means a hospital and doctors and nurses and physiotherapists that are very well prepared to treat this disease.